Hello, everyone. How are you doing today? And welcome. Today is Wednesday, October 18th, and today is an Ask the Expert. So, what that means is this is all about you all. So, we only have a show if y'all entertain us, or not entertain us, engage with us. Please don't entertain us and don't feel that kind of pressure. That would feel horrible.
What sort of comments are we about to get now that Chris is telling everyone to entertain us?
No, I meant engage with us. Oh my God. Can you imagine? Like my OCD back in the day would have been like, oh my God, I'm supposed to come with like juggling act or something. This is so much pressure just to come to a live stream. No. Please don't feel like you have to entertain us. Just engage with us. Hey, Bailey, how you doing? Bailey says hi. Whatever social media platform you're on, go ahead and let us know where you're from. Say hi to the people in the comments. Let us know who you're here to support. But Ask the Experts is such a fun live stream because it's really just about supporting you all with what you're going through. So we're really here just to kind of answer some of your questions, give you some guidance, some education, some resources. So really excited to have you all here today. So quickly, I'm going to do some announcements real quick. And then Liz, you and I haven't introduced ourselves in a while. So we'll definitely do that.
Today.
What?
Yeah, let's do that today. Do you want to start with that or start with announcements?
I'll do the announcements real quick. So always remember, we're super excited to have you. And also this live stream is educational, is not intended to replace therapy. So for treatment related questions, you can definitely find a therapist at iocdf.org/find-help. Also, if you're really struggling, go to a local emergency room, dial 988-911 or go to 988lifeline.org. And we want to create a safe space and be respectful to everyone. So at the end of the day, we're all here to support each other. And this is being recorded on several social media platforms. Two quick announcements. Don't forget that the online OCD conference is this weekend. So the International OCD Foundation throws multiple conferences, but two really large ones. We have the in-person in San Francisco, but we have the online conference, and that allows people from all over the world to come to a conference, see some of the top OCD experts, to hear from people that are in recovery. We have a great keynote of community members. We have a wrap-up panel with some top therapists. So please check it out at iocdf.org/online OCD Con. And that way you can find out more information and register, and everything's being recorded. So if you are like, darn, I can't make it this weekend, don't forget everything is being recorded, and you can access those recordings up to 60 days after if you register now. And then last announcement, join us next week. We're really excited because Michelle Massey, who's one of our close friends, is going to be on the live stream for a Lunch and Learn next week. We don't know exactly the topic, but we've been talking with Michelle about treating the whole client, values-based exposures, dispelling some myths about ERP. So we'll come up with some cool topic, but we're going to be covering a lot of really important things, and we're excited to have Michelle on the live next week. So that'll be next week, 9 a.m. Pacific. Noon Eastern, the same time this live is. But I realized we haven't introduced ourselves in a while. So do you want to say, introduce yourself first, Liz?
Yeah, happy to. So my name is Liz Mackingville. I am an international advocate for the foundation. I've been doing advocacy work for IOCDF for like over 20 years, which is kind of crazy, or nearly 20 years at this point, I guess. Soon, not 20 yet, maybe, not to age myself. But I've been doing advocacy for a long time, and I love it so much. But it's really shifted for me. When I first started, I started as an advocate, as someone with a lived experience, and then I ended up going back to school, doing education and training in OCD-specific work, so that now I advocate really much more from a treatment perspective and as a professional. So I'm a licensed clinician in the state of Texas, and I am the director of the OCD Institute of Texas, which is a residential and partial hospitalization program specific for OCD, anxiety, and related disorders. So really excited and honored to be here. And I share both just because Wednesday's live streams are professional. So Chris and I lead them, and we bring on different professionals, but we lead them and really give feedback around treatment and specifics from that professional clinical lens versus just the not versus, because not always one or the other, but versus a personal lens, which is very different than a treatment lens.
Yeah. And where are you coming from? It looks cool background.
I know. Sorry, you guys. So I have a board meeting this week. Today, I'm in Dallas. I've been all over the place this week. I was in Boston yesterday, and then today I'm in Dallas for a board meeting. So I'm in a hotel. So I'm sorry if it's loud, but here we are.
No, it's actually not loud. The audio is perfect, and it's just so pretty. So I was like, oh, okay, you definitely beat my apartment.
You can see over here, you can see the exit sign. So there's the hotel entrance.
No, but it's pretty. Is that a Christmas tree or just a really pretty tree?
It's like a really pretty look. I can show you guys. It's like a really pretty flower space that they have on the ceiling inside. So I was like, well, that'll be a good background.
It's gorgeous. Well, hi everyone. My name is Chris Tronson. I'm a lead IOCDF advocate, and like Liz, that I started out advocating for OCD. I always felt like, how did so many people have this disorder, but nobody knows about it? Or when people do know about it, it's typically stigmatized. So advocated started that way, but decided to become full circle and become a therapist and a licensed clinician here in California, where I treat clients with OCD, body dysmorphic disorder, and related disorders at the Gateway Institute in Costa Mesa, California. And then I also am a board member, like Liz, of the IOCDF and OCD Southern California. I'm vice president, and just really trying to get resources out to the community. So super excited. Liz and I are speaking together with our guest next week, Michelle, at the conference this weekend. So we hope you make it out. Liz, I have to talk to you about something before we jump in. So the Newport Beach Film Festival was this weekend. It's still happening this week.
Oh, no.
And yeah, and so we got reached out to. I have pictures from last night, so I'll have to post them. But we got reached out, and the director of a film called Exposure reached out to the foundation and said, hey, I have OCD. I've dealt with really bad OCD for a long time. I'm really frustrated with the stigmatization of OCD and its treatment. And I made a film. I've been working on a film for the last 2 years about OCD, and I really made it different. And so they sent a screener. I know that Fran saw it, Jenna Overbaugh saw it, Krista Reed saw it, Val saw it, and they really liked it. Now, it's obviously a thriller, so it's not going to be literally just like, it's not a documentary where people are just doing therapy, but it's actually where it's like a movie. And so I'm not going to give too much away, but the main character, Tanner, has OCD, and his OCD he had an incident, but then he has OCD, and he's always had OCD. His wife in the film reminds him of that, but he has the OCD, like the fear of being poisoned. And so he'll kind of like open the fridge and sniff the food, or before drinking water, he'll kind of hold it up and look at it, or taste it on his tongue, or kind of sniff it to make sure that it's okay. And I could so relate, because that was one of my subtypes. I didn't necessarily fear I was going to be poisoned. I was more so fearful that my food would be tampered with, or my water would be tampered with. I remember reading about like food being tampered with, and like Tylenol and stuff. And so I think what was so profound about the film is the beginning of it, in the scenes when the guy's really struggling with like drinking water and eating food. It really captured what it's like to have OCD. Somebody just absolutely struggling just to function. He's trying to function at work and function at home, a lot of rituals and things like that. But it was a really, really cool experience. Liz, did I lose you?
I don't think so.
Oh no. Okay, you're just looking so intently. You didn't blink. Yeah.
No,
So
I've been seeing this. I was pulling stuff up, Chris, but like I've been seeing this all on social media, and it's been so exciting. So I'm so excited to hearing you talk about it. But the question I have, because I can't figure it out, is how do we find it? How do we see it? What are the options for those of us that really want to see and support?
Yeah, so I will ask him if we can do. I think it'd be cool to try to do like an IOCDF screener, because the problem is, and Ethan knows this with his films. What you do is you go and you get you go to different film festivals, and the goal is to like win awards, get attention, so you can get a distribution deal. Because a distribution is a company, a film company, that will then pay for it to be in theaters and put it out there for people to see. And so that's kind of where it's at. So this was the world premiere of the film at any film festival. Obviously, with the strikes and things like that, everything got pushed back, but luckily it was able to be done. But it's not open yet. But I really got to hang out with the director. I mean, he had a therapist on set. He's gone through OCD. And when you watch the film, it's crazy, because you're just like, oh my God, only somebody who's gone through treatment or is a therapist or has OCD could do this, right? So yeah, no, it's going to be something where I'm going to talk to him and see if we could do like a IOCDF premiere or something. Would be cool. But yeah, no, I mean, it just handled it really well. I think what was also cool is like the main character, who's really afraid of being poisoned, goes to a support group, and that's a big part of the film. And they show scrupulosity, they show sexual orientation OCD, contamination, just a lot of the real subtypes and stuff. And so talking to I got to be part of the Q&A at the end, and a lot of the actors actually got signed on because they have OCD. And so a lot of them talked about their own personal experience and kind of played the role of somebody with that subtype because they have it. And Cash asked about the reviews. So far, it's gotten really good reviews. Like I said, some of the people in our community reviewed it, but it's also got some general film reviews. But I think what I'm most excited about is just Finally having a film that really represents us. It didn't feel like it was poking fun. It felt like the torture. Like I said, Liz, I'd be curious, like the beginning, how you felt, because I just watched it. I had similar subtype, but I think even if you don't have the same subtype, just the exhaustion of like trying to eat food, something feels contaminated, so you throw it away. So you try another meal and that doesn't work. And then you're asking for reassurance. And then you have to go to work, but you're distracted at work and you can't really focus because of the OCD. And it just was like, it was great. But what was cool is they let me actually intro the film. They let me do like a 5-minute intro and talk about the IOCDF and like their community and resources. And a lot of people came up to me after and were like, oh, that really set the scene. But the cool thing is the people in the audience weren't all people with OCD. I mean, there was a handful and there was the cast and crew. But it's an open film festival. It's like one of the most popular ones in Orange County, actually the most popular in Orange County. So it was filled with people that have never heard of OCD. And at the Q&A, that was the question that I asked. I was just like, who here feels like they shifted their understanding of OCD from like Khloe Kardashian and sanitizing to what it is? And that started a whole conversation about people were like, wow, I need to change how I think and look at OCD. So anyways, we'll have to do something with the IOCDF, but I just wanted to say how cool it was to have a film really represent us and be in like a major film festival.
I love that so much. And I just love seeing how many people are advocating in so many different new ways. It is so exciting. And so I just want to say thank you. Thank you for highlighting it, Chris. Thank you for everyone who put it together and all the work that went into it and the people it's going to touch. Again, as IOCDF, our goal is to not just promote advocacy through our webinars, but through all these different avenues, right? Film, creativity. We've seen people do it through artwork, through, right, all different ways that is just so incredible. And what we know is that advocacy reaches different people in different ways and through different avenues. And so the more we're doing it, the better. So this is so awesome. We love that. Yes. And hopefully you might consider, I know IOCDF at the conference in person has done some like film, I don't know what you call film screenings, so maybe that would be a potential for so many people who are noting that they really want to see it.
Yeah, the last thing I'll say is what's cool is the film's called Exposure, and the clients in the session do exposure and response prevention. And I think what's really cool about it is they talk about the response prevention. They talk about like how to kind of get support. And I think the best part is like you see the client, although difficult doing the exposures, like you see just the relief that he gets from doing it. And the same with the other characters. And you actually see when I was interviewing one of the guys, he was talking about how like, he's like, I don't know if you noticed this, but throughout my character doing ERP, I started getting more comfortable and relaxed and dressed different and was happier in the film. And I think it showed that people can get better and hope. Now, I will remind everybody it's a movie, so there had to be like some stuff to make like the general public interested. So that's what was crazy. A lot of people who don't have OCD were like, hey, the film was good, even if you don't have OCD. So yeah. So anyways, I just wanted to highlight that. Really excited about that.
Love it. Excited to see more and hear more about it. And so we are going to move to Loretta's question at 11:10 my time. Question: I'm working with a veteran who has multiple issues like flashbacks, nightmares, anger, and paranoia. He also avoids crowds, restaurants, and doesn't drink water, hotels, or driving. He loves to be alone. Is there any similarity in treatment for him from OCD? He refuses to take meds because his parents stuff with opioids, and he feels like pharma companies are not pro people. Some of this sounds like OCD. Any advice? So I'll hop in. So I don't know that a lot of it sounds like OCD. Definitely sounds like some anxiety. It sounds like potentially agoraphobia, but also panic. So when we see individuals not going to crowds and restaurants, I'd want to know more about not driving and drinking water, because a lot of this, again, so many times we can see some symptoms that might look like OCD, might look like anxiety, but really we need to do a thorough assessment to better understand what's going on. When we're talking about flashbacks, nightmares, angers, paranoia, I always really want to do a thorough assessment for PTSD, especially someone who's a veteran, because a lot of this actually could all fall into the PTSD realm. So could be PTSD, could be panic, could be anxiety, right? There's a lot of things it could be. But again, we always want to start with a thorough assessment. I love this question because I want it to kind of lead into a bit of a discussion, Chris, on how important it is for us to make sure that we're really, really thoughtful about assessing and understanding symptoms first. So what I mean by that, I actually am working on ADAA is the Anxiety Disorder Association of America. I'm working on a conference submission right now about differentiating. And one of the things we're really talking about, Emily Bailey and some other providers are on this submission, is we've been talking about how dangerous it is, if that's an okay term to use, but how dangerous it can be for sure, when we find that providers, and I'm not saying this is happening here, Loretta, but it just is launching me into a great conversation. But when we can find that providers sometimes will allow patients to over-identify symptoms as being OCD or maybe as being something else, when really they're better identified as another diagnosis. So we've talked about this before, Chris, but we've talked about how for OCD, there's an evidence-based treatment, right? ERP is the most evidence-based research behavioral therapy intervention that we know has the highest level of efficacy and outcomes for OCD. It is the sure fact, right, for first-line intervention for OCD. But a lot of patients with OCD have comorbid diagnoses, right? They may also have PTSD. They may have panic disorder. They may have generalized anxiety disorder, BDD, depression. And what we know is that treatment for those comorbid conditions might look a little bit different, right? Traditional ERP might actually not be the most evidence-based intervention for that diagnosis. And so can you talk for a second, Chris, about how as clinicians, how do we differentiate? What does that look like? But also, how as patients can we have an open mind to be really thoughtful about if something might not be OCD? How do we talk about that with our provider? How do we process that if that's a discussion that's being brought up?
Yeah, I'm glad you said that. One thing that I do is I always do an assessment before starting with a client. That's just what I like to do. So I do like a 30-minute assessment before even our first session. And the reason is because we are in network with Kaiser, and often, people are misdiagnosed and come to us, or just in general, like family members will think that their loved one has OCD and request that they come and see us. And what I find a lot, for instance, is there'll be a client who has autism, and there's a lot of different sensory stuff, repeated stuff, getting very interested in things. And the family members will say, oh my God, like my loved one has OCD. And as I'm doing the assessment and I don't see any OCD in the client, I do see autism, I'll ask, and I'm like, okay, I know your loved one was diagnosed with autism. Where'd you get the OCD diagnosis? And they're like, well, he's like really compulsive with the planets. Like he researches the planets and he reads the planets and he looks up the planets. Like that's compulsive. He's obsessed with planets. And I'm like, no, in autism, that's one of his loves. I mean, I have a nephew with autism who gets very focused on like a movie and watches it repeatedly, or the dinosaurs or other things. And so I don't want that person who doesn't have OCD to come and see me when there's a provider that can work with him, that can help him with some of the life skills that he may need with autism. Or a lot of times, like in the question, somebody might have PTSD and maybe they do have OCD. I mean, PTSD and OCD, we see that. But they'll maybe think everything is PTSD or OCD, or they're seeing somebody for PTSD and the OCD isn't being seen. And so OCD has a very specific treatment, has very specific language, specific education. And so if people aren't properly getting diagnosed, somebody can move forward and not get the correct care. The second part.
I'm going to hop in for a second because I wish I was in my office today and I'm not, but like I will literally take a whiteboard. Like I have this big rolling whiteboard and I will literally take the whiteboard out with patients and I will do like a OCD, sorry, y'all can't see my hand, an OCD section with a line and then like other symptoms. And I'll talk about, hey, what are all of your main symptoms you want to address in treatment? And we'll start to take those as people say them and start to line out which ones fall in OCD, but then which ones don't. And then what we'll do is say, okay, the ones that don't, let's start to talk about what they're better defined as, right? What sort of symptom is this? What could this be better characterized as? And then we start to jump into what are the evidence-based treatments for those symptoms, because it may not be ERP. And again, ERP is, so many times people say ERP didn't work for me. One of the things I want to know is like, what sort of ERP were you doing? I want to know, what did ERP look like? I want to know, were you actually doing it all the way? Were you ready? But I also want to know, what symptoms were you trying to treat? Because if you're trying to treat PTSD symptoms with ERP, it's not going to really work because ERP is specific for OCD.
Yeah. And the other thing too is your second part of your question. I mean, a lot of times people are struggling with something else, but they don't talk to their OCD provider because they're like, oh, I know this is an OCD. What I always encourage people to do, if you're watching this, if you have OCD, but maybe there is some other things that you have that don't really fit into OCD, you don't hear other advocates talking about having it, you don't see any, clinicians having it, doesn't fit in the DSM, et cetera. A lot of times, like we may not necessarily work with clients with a certain disorder or certain experience, but a lot of us have really good referrals. A lot of us have a lot of good colleagues that might do it. So I know sometimes it's hard, but I'll see where people are afraid to bring up some of their other symptoms because they're like, oh, this is an OCD. But I've had clients bring up stuff where, they're really struggling with something. And I'm like, okay, that sounds much more like this. Let's find you someone. Last thing I'll say on it too is sometimes people will be experiencing something and I'm like, that could be three different things, right? Like if somebody is somebody will say, okay, well, my kid just absolutely won't sit at the table and eat. Well, could it be misophonia? Like, is there certain sounds of chewing that bother them? Is it because it's OCD? Maybe the chairs are contaminated. Is it because just life stuff? It's a teenager who doesn't want to eat with family. Is it ADHD and they want to walk around and they can't sit at the table? Like there's different reasons why somebody may be struggling with something that could be different things. Maybe they have depression and go in their room and eat because they're depressed. So it's important. I always say with a client and with their loved ones, like, let's get underneath, like what's going on, what is the reason, what is the purpose behind that behavior, and that will sort of guide us to maybe what diagnosis is best fit.
And we're going to hop to the next question in a second from Loretta, but the thing I really want to point out for clinicians listening today, I think sometimes as clinicians, we get anxious when we hear patients over-identifying things as OCD. Sometimes I think we think, oh, well, that's okay. Like, what does it really matter if they think it's OCD, but it's not? Or if we're hearing potential personality disorder or another diagnosis, right? But if I use personality, like sometimes there's anxiety of like, well, I don't know if I really want to tell them that. Do I feel comfortable diagnosing it? What I want you to be thoughtful about is that it isn't helpful to allow mislabeling to happen. It's actually really damaging to the patient. And most of our patients, right, will say things like, so I'll give an example, but a lot of times when there's like a thought around if there's an autism spectrum disorder going on, sometimes providers are like, well, I don't know if I want to talk to them about that. Will they want to hear this? Will it be hard? And most of the times patients talk about feeling really validated when it's talked about because they've been wondering for a long time why things don't make as much sense to them or why they're struggling socially, and having a name to what's going on also allows them to get appropriate treatment. And we know there's really effective behavioral interventions for all disorders, but especially like autism or other ones that we again want to lead them to that right treatment versus let's treat it as OCD, but then it's not really helping them with social skills, and that doesn't make sense, but it's because they needed specific social skills intervention. So, again, it's really important for the client and the clinician. And if it makes us uncomfortable to bring up these differentials and to talk about it, that's on us to work through as a clinician, but it shouldn't be on your patient to have to be the recipient of that when we know it can prolong their outcomes and prolong them getting the effective treatment. The next question leads right into this from Loretta at 11:13 my time. If I'm meeting with a new client and they describe a list of OCD behaviors, when do I mention OCD? When is it too early? This is a great question, and you're going to hear a different answer from Chris and I than you might from other clinicians because our specialty is OCD. So most of our patients are coming to us on day one to get assessed for OCD and anxiety. So we're talking about it day one. But Chris, talk a little bit about, as a clinician, what would make you diagnose OCD? And just because someone has OCD behaviors, how do you assess, is this OCD, is it not? When do we talk about it? And when do we think about OCD specific interventions?
Yeah, I would say, what's a little bit difficult to answer this question, like you're saying, Liz, is I would say, like, I work with basically like 100% of my clients either have OCD or BDD or both, right? So almost every client is already coming because they've either had a diagnosis previously or they show symptoms, et cetera. But what I would say to a clinician that does see multiple different types of clients, right? Some people don't want to specialize only in OCD. They want to see OCD, but they also treat PTSD and other things. What you would want to do is I like the YBox 2. I feel like it's the strongest assessment, but there's a lot of different assessment tools. In fact, on the IOCDF's website, they even have assessment tools. But if I have a client, let's say you're working with someone, Loretta, and you're not doing like an OCD assessment, but as they're talking, you're seeing a lot of different OCD symptoms. What I would do is I would say, you know what? I'm noticing, I don't want to diagnose you yet, but I'm noticing that some of the symptoms you're talking about fit into OCD criteria. So I often will bring out the DSM, right? Like I said, I don't have to do this often because most of my clients come for OCD, but I'll really read the criteria and ask them and go through it and say, does this feel like it's what you're experiencing? If they say yes, then I will lean on those diagnostic tools and I'll start to, the assessment tools, and start to go through them. And if somebody is matching and, checking things off in the YBox inventory, they're scoring high on the Y-BOX, some of the other OCD assessments that we have, then what I like to do is go further into the assessment process. What are the obsessions that you're identifying? What are the compulsions, either extra behaviors or avoidance behaviors or reassurance? What are the thoughts like? What is the experience like in your head? And I think an assessment is so important because you want to do a thorough assessment. Then Loretta, after going through that process, you can then talk to the client about the diagnosis. The reason I always, like I said, I don't worry about the OCD diagnosis, but a lot of times, sometimes clients might think they have autism or something else or depression. And I really want to do a proper assessment because I don't want people to leave my office with like 7 diagnoses, especially if they don't have something.
Took me a minute to get to my unmute button. Here's where the life I'm at this point. I love that. Yeah, I think that's so important. And the next question is really great, and it actually leads to what you were also just talking about from Apoorv. Is there, they said an online screening tool for the IOCDF community members would be so great. And Chris was just talking about this. So our main screening tool for OCD is called the Y-BOX, the Yale Brown Obsessive Compulsive Scale. And what Chris was saying is that when patients score a certain score, it helps us understand. So what I want to say is the typical clinical cutoff for Y-BOX is a 16. So what that means is that traditionally what we say is that a clinical cutoff score of 16 means that above a 16, a patient probably meets diagnostic criteria for OCD versus below a 16. However, what I will say is that many patients might underreport or they don't know how to answer the question. So you really should be using your clinical guidance and tools to determine, is there a significant impairment in their life? The DSM really describes this for OCD as being an hour per day or more of impairment. But for me, like my focus is if you're showing up in my office, you're probably impaired. If it's primarily OCD symptoms, and if I can make sure they're not better defined as something else, I'm going to understand it as OCD. So what I mean by that is that somebody can come in with 2 hours a day of checking behaviors. I might think, oh, that's OCD. But as I do my clinical intake and get to know them, if they have had, let's just say, a recent or a trauma and they meet criteria for PTSD because they were recently robbed or they had a home invasion, right? That checking behavior might all be better understood as PTSD versus OCD. And so again, I'm using my clinical tools and different measures to figure out what are they scoring high on and what makes sense for their diagnosis. So again, this is where that clinical insight and screening really makes such a big difference. Stacy, I also loved the Game Changers event that Christy put on last Saturday. It was so much fun. It was so awesome to see so many people together. So Chris, let's go to a question from Cindy at 11:16 my time, Brendan. Hello, my adult daughter has intrusive thoughts and has OCD. It'd be helpful to have group therapy and more exposure and response prevention therapy providers that will accept insurance. It's really hard to find an ERP therapist, and majority of them don't accept insurance. How can people on disability afford to get help?
Yeah, Cindy. I mean, that's something that we actually had a meeting yesterday with the IOCDF, the Tuesday. We have these meetings on Tuesday morning. And one of the things that Justin, I always butcher her last name, Justine DeJager, and Liz Lindley and Steph at the foundation were really working on were these kind of political advocacy phone banks that they've been doing and want to get the community involved, where you can kind of put in your zip code, find your local providers and call and really request resources for OCD. I always remind people, my nephew has autism, and in 2012, I believe there was a law that was passed that all insurance companies had to pay and cover autism care, and my nephew gets full coverage. Insurance companies don't see OCD as that. So a lot of us really try. I mean, where I work, we're in network with Kaiser. I know NoCD takes a lot of insurances. A lot of times we can do like single case agreements. There's actually a really good webinar, which I will find in a second because I can't talk and do something at the same time. But we did a really good webinar with Dr. Fred Penzel from New York, where he talks about the different ways to get your insurance to cover. I know that USC under Barbara Vinopin, they've worked with the LAC hospital, and they take Medicare and Medi-Cal and Medicare. I think the biggest thing is to talk to your, like using I don't know if it's live yet, but as soon as it does go live, using that tool to start to reach out to your local clinicians. I always tell people when you're thinking of who to vote for, see what their belief system is on insurance and getting better insurance coverage. It's hard because as clinicians, what happens is like we were in network with 2 other insurances, which I won't say out loud, but we didn't get paid for a whole year.
You're allowed to do that.
I don't know the second one by heart, but it was MHN. So we were in network with MHN and we worked with clients for a year and never got paid. And then finally the insurance company was like, you know what, we're not going to pay you. Like, sue us if you want your money. And so that was a year. I mean, it's not my business, but that was a year I got paid, but my company didn't get paid for a year. And so that's the hard thing is like, yeah, there was a therapist. I don't want to say her name out loud, but because she was talking in private, but we were having a talk after an OCD SoCal event, and she's in network with insurances. And then out of nowhere, the insurances came back and said, "We reject all your notes. You owe us $25,000." So I think it's hard. What I didn't understand when I was going through treatment, and we were very frustrated that our insurance didn't cover it. We're never mad at my therapist, but now being a therapist, I have a lot better understanding of why it's so hard, because insurance companies just don't pay us. Or they won't pay us the normal rate. And so it's difficult.
You guys, I've been wanting to post about this, and there's been a lot of other stuff going on, so I haven't, but I'm going to soon, about just what happens with insurance and how outrageous they make it. And it's these little loopholes. So I'll give an example, but I had, was it Aetna? I think it might have been, I can't remember now. Maybe it wasn't Aetna, it might have been anyway, whoever it was. We submitted all of our stuff for our clinic to be a network, and they came back with 2 simple questions that I'm telling y'all I could have answered in 30 seconds. They could have called me and asked me. And so their response was, "We have 2 questions on your application, therefore you can reapply in a year." And I'm like, wait a second, you have 2 questions and I can't answer them. Instead, I have to wait a year for our patients to even think and see if you'll get a network. Like, it's ridiculous. So, right, they make it so difficult on us. However, here's my thoughts. Number 1, you can always request a super bill from any of your providers so that you can file for out of network with your insurance. You have to be an advocate. There's an incredible article on IOCDF by Fred Penzel, I think Chris mentioned it, that talks about how to navigate that. Remember, you are advocating. Number 3, I want you to look at in your state, right? Because now we can do Zoom. Are there any OCD centers? So OCD centers are clinics that tend to be bigger clinics like ours, so residential PHP big centers, or academic centers. So in Houston, Baylor College of Medicine is also an OCD program. Most centers have students that are trained by us that we can offer sliding scale rates. And so our clinic can offer $50 or less per session. And so for incredible ERP work, right, that's supervised by incredible clinicians. So there's really good options if you really start to look at, is there any academic centers or other big treatment programs near me? And let me reach out to them to see what options they have available and can help us navigate. So always think about that.
I was just say real quick, Liz, Brennan, I put 2 links in the private chat that you can put for the public chat. One is from Peace of Mind with Fred Penzel's article. The second one is a live stream we actually did, Liz and I did, with Fred Penzel. So please watch both that live stream and read the article, because he has some really, really good tips. And look, I just did a sleep study and my insurance just rejected covering it, even though it was in network, and they want me to pay $1,300 and now I have to fight. I mean, it's exhausting. I don't have the time to sit there and call, but I'm also not going to pay $1,300 they said they'd cover. So that's the other thing. And that's what Fred talks about, is like the need to advocate for yourself.
Totally. The next question was, now, of course, I went to the bottom. I lost. This is what happens with the chat. Things go away. We have so many questions, Chris. Okay, so we've got to jump in and get through them. My next question, where is it, Brendan? You guys, I'm almost there, I promise. I know I had it in front of me, so I want to, lots of people wanting to see the film too, Chris. The next question was about harm OCD, and okay.
Yeah, it's Kyle's, yeah.
Here we are at 11:19. Do you see harm OCD and religious OCD overlap?
Yeah, absolutely. It's funny because we were talking about this in my support group I run, and they were asking, like, have you ever worked with someone, Chris, that only has had one subtype forever? And I had, like, in all the years, I was like, I've met one client, right? Like most people, it changes, but it also can overlap. And so absolutely. So people can have harm. One common thing that just popped in my mind right now is I have clients that have harm OCD, and they fear that they're going to harm religious figures. They feel like they're going to harm Jesus in some way, that they're going to harm potentially their pastor or their priest. And so it can definitely correlate to each other. A lot of times, there will be an overlap. So for instance, like a client might have contamination OCD, so they don't go to their friend's birthday dinner because they don't want to be around around all those people. And they have OCD around harming people, but more on the emotional sense. And they feel really guilty. They're not showing up to their friends' birthday parties, so they're struggling. So yeah, Kyle, I mean, that's absolutely can happen. And so most people will have multiple subtypes. And so with that, religious OCD and harm OCD, I would love if you want to put in the chat, Kyle, if you're open, an example that you're dealing with, because we can only give kind of like just a generic example. But like I said, I've seen it where people have harm where they're at church and they're friends with a lot of people at church, and they have scrupulosity because they don't want to go to church and they feel like they're going to go to hell. But when they're at church, they have their harm thoughts. So they don't want to go to church because they're around a lot of people and are afraid they're going to harm someone. So it's really that. What I always talk about, I saw Michelle Massey posting a lot of this on the Facebook group. You want to get to core fears. Core fears is really going to help like link it together. So what I mean by that is a lot of times when you look at your different subtypes and start to go deeper, there's like this fear underneath of what you're worried about will happen. Who are you going to become? And you'll start to notice that those core fears kind of blend together. And then we focus less on content. We focus more on the mechanics. Real quick aha moment a client had in session yesterday. He was just saying, he's like, I'm kind of starting to realize that all of my OCD, it's like, I'll get this thought, and OCD is not an expert in that field, but I'll treat it like it is. And then I'll just kind of live my life on that assumption as if I know what I'm talking about. But I realize when I come in here, I'm just kind of like getting a thought and then going with it. So when you learn the mechanics and the core fears, the subtypes you start to recognize matter less. But in the beginning, it is super important. But yes, they can absolutely overlap. I don't know if that's your same feeling.
Yeah, no, you did perfect. I'm trying to read all the questions and get to them because y'all know I hate not getting to questions. So I'm going to answer a couple quickly as we kind of keep moving through. But yes, we try our best to answer all of y'all's questions, and I love y'all's chat and discussion and forming a community with each other. Chris, we are really bad. Sorry, you guys. Chris and I are really bad about breaking terms down, so we need to. So OCD has multiple different subtypes. So within the OCD umbrella, so to say, we have subtypes that include sexual orientation OCD, sexual intrusive thoughts, harm OCD, harm to self, harm to others OCD, scrupulosity, which is the religious form of OCD, perfectionism, just right OCD, contamination, right? So there's kind of, when you think about OCD, we're not really saying, okay, does someone meet criteria for an OCD symptom? It's, do you meet criteria for an OCD diagnosis overall? And then we start to understand what are your current symptoms within those subtypes, right? Because there isn't any one symptom that we can say, oh, that's definitely OCD. It's across the board. Why are you doing that symptom? What leads you to do it? What's the functionality, right? There's a lot of questions. In different states, different individuals can diagnose, right? So a lot of us as mental health clinicians can diagnose OCD based on a clinical assessment and an intake. Comorbid. So someone asked like, what is kind of like, where does OCD fall in versus subtypes versus what is comorbid OCD? So comorbid just means, is there something else present? So is there two conditions happening at once? So for many people, they have OCD with a comorbid diagnosis. So what we mean by that is you might have like OCD and depression, or you might have OCD and borderline personality disorder, OCD and eating disorder, right? So when we're saying, is there a comorbid condition, we're not saying a comorbid subtype. So we're not saying like, are there two subtypes you're dealing with? We're talking about, is there another diagnosis in addition to OCD? And I'm sorry, sometimes Chris and I just get excited and we're talking and we need to break these terms down a little bit more. And Chris, we probably need to do a clinical language 101 presentation soon, where we also break down ERP and cognitive therapy and subtypes and OCD and the different, and like really do an educational talk around what is OCD, what do subtypes look like, all of that, because that would be really important. So categories. Again, I do think it's really important to dual diagnose. And yes, I totally agree. Undiagnosed and untreated OCD, or any disorder for that matter, can lead to the emergence of other disorders in different ways, right? And those being onset for a lot of different reasons. And we see this a lot. OCD symptoms can start as early as 2 to 4. Someone said, like, can you experience symptoms at age 5? And you absolutely can. All right.
Can I do a question that I see?
Yes, please.
Yeah. Brennan, if you could put up Keyshore's question at 11:20 or 12:23 your time, talking about feel right or just right OCD. Yeah, so I'll jump in first, and then so just right OCD. I'm glad you asked this question. Normally we call it just right, but sometimes people say feel right. What I like about this question is because um, it's funny because I was talking to Allegra about this, and I always say, like, in the second half of your treatment, subtype doesn't matter. You're really learning about core fears, and you're learning about like the mechanics of OCD and how it works and how it tricks you and all that great stuff, right? But in the beginning, it does matter because each subtype has unique kind of experiences. And with just right OCD, typically somebody may not have the typical core fear of like this bad thing will happen. Most of the time, it's like if I don't do the compulsion, I just won't feel right. Sometimes it could be balance, like maybe you bump something on your right and you want to, even it on the left. Sometimes it's like sitting down in your chair and it didn't feel right, so you get up and keep sitting down until it feels right. I've had clients where it's setting something down and they keep picking it up and setting it down. Typically, it's not really like, sometimes it can be, sometimes it can be mixed with magical thinking where it's like, if I don't set this can down right, my wife might be hurt. But I would say the majority of clients that I work with, they'll say, Chris, it's not, I can't tell you something that's going to happen, but the feeling I get is just so uncomfortable. And then when we go to core fear, they start to realize, well, the belief is that this uncomfortable feeling will last forever until I fix it. I won't be able to pay attention at work or at school. I won't be able to like engage. I won't be able to be myself. And so the only way that we can believe that is if we have this concept that this feeling can last forever. And as we know, and what I do with clients in the psychoeducation phase is those feelings can't last forever. So what the exposure looks like with a client would be to test it out. Let's test it out for a little bit, right? Like, can you set something down incomplete or just wrong, right? I always call it just wrong is the treatment. Like, set it down just wrong, and let's see if we can move on to something. And over time, a client will learn, like, hey, that feeling that OCD is threatening will last forever really doesn't last forever. It lasts for a short period of time, but I'm not becoming a slave to the OCD by giving in. So thanks for asking the question. It's a very common subtype. And I think it's important just to know that little nuance of what the fear seems to be for most people.
Yeah, and I love that you hit the nail on the head. It can be magical thinking, but it also can be based on, I might have anxiety forever, I might feel distressed forever, right? So I just have to do this behavior. And remember, sometimes there's overlap. Sometimes it's like, oh, this feels a little contaminated, but it's not really rooted. The core fear isn't rooted in my phone feeling contaminated and being sick. The core fear can be rooted in like, but if it feels a little contaminated and I feel uncomfortable, I might feel uncomfortable forever. And so the core fear is still based on that uncomfortable anxiety forever versus like someone getting sick or dying. So again, this is why with every single OCD symptom, as a clinician, we want to really understand what's at the core, what's leading to you wanting to clean that phone versus just focusing on whether or not you clean that phone as being the main treatment goal. So we'll talk more about that. Chris, I would like us to do, we talked about this during OCD week last week, an entire lunch and learn. Brendan, if we can make a note on core fears and how to talk about and think about core fears and the way we integrate those into ERP treatment. I think that's really important. At 11:31, Apoorv, how does OCD existing with comorbid PTSD make things worse or difficult?
So I just put a note on our question thing.
Answer if you want.
Why don't you start and then I'll jump in. I was just putting a note to remember the core fears.
There's so much work that's been done in OCD and PTSD. Caitlin Pinciotti and others have done amazing work there. And Caitlin has actually developed a screener to really help differentiate OCD symptoms versus PTSD symptoms. So definitely would recommend kind of checking that out to kind of be able to know the difference in the two and what you're looking at. But treatment is different, right? So we want to be able to understand what are the OCD symptoms and how do we treat those as OCD, and what are the PTSD symptoms and how do we make sure we're treating those as PTSD. So with PTSD, we're doing evidence-based interventions for PTSD. That includes cognitive processing therapy, prolonged exposure, and then there's research now that shows EMDR as being effective as well. And so it's a little bit different, right? It's much more of a stepwise approach. We're less focused on just exposure and response prevention and more focused on really helping you get unstuck. So when we think about PTSD, I always think about like this traditional bell curve. Most people, when they experience trauma or a traumatic event in their life, they naturally recover, right? They have different symptoms of trauma, but eventually they kind of naturally recover and get back to their baseline. When you have a diagnosis of PTSD, you get stuck in that recovery process. So as you're on that journey, you're stuck somewhere. And so part of treatment is really helping you get unstuck. So we're doing a lot of work on what are your stuck points, helping you understand trust, helping you understand safety in different ways so that we can get you unstuck. When we do, typically people will then finish that bell curve. They're like released from their stuck point and they're able to recover naturally. And the PTSD is really, really wonderfully addressed. And it isn't necessarily going to show up in different areas of their life continuously throughout if they've really addressed their stuck points and done the treatment, versus OCD being something that is not typically rooted in a traumatic event, right? It can onset, but our OCD shifts to all sorts of random things and is very different and looks very different both clinically and how we approach it than traditional OCD, than traditional PTSD. So again, we want to understand both so that we're treating them differently. Treatment can look a little trickier. I want to be candid about that, and can be a little bit more difficult in different ways, just because sometimes things that look like OCD can be PTSD and vice versa. And so you really want someone who's equipped in both. You want to be working with a provider who understands how to treat PTSD and is trained in that, right? Not just you've read a little bit, you're trained in the treatment of PTSD and you're trained in the treatment of OCD so that you can do both. If you can't find both, work on finding providers who do it individually. So somebody who does trauma work and someone who does OCD work.
The only thing I'll add is I put in the chat, I think Brendan put it in the chat. We just did a Awareness Week live stream. Allegra is part of it, Alex Reynolds, Bronwyn, and myself, and we did a live stream on PTSD, trauma, and OCD. You covered it really well, and the one thing I was going to add is, like, sometimes you'll provide or who will do both or work with a team, and you already added that. So I have nothing to add, but definitely if you want to watch the live stream, it really talks about what Liz just said in a full hour. So it was a really good live stream. People enjoyed it, and for clinicians, it'd be good to watch as well.
Totally. So to answer, Amy talked about, can we talk about these random surveys that say they diagnose OCD? Yeah, be really cautious of those. We want you to look at validated, reliable measures. The Y-BOX is really the most validated and reliable measure for adults. We use the CyBox, so CY-BOX, children's Y-BOX for children and adolescents. And then, of course, the DOCS, the Dimensional OCD Scale, which was created by Dr. Abramowitz, is also a really good scale. But be really thoughtful and cautious about a validated clinical measure versus a random survey that's been created online. I couldn't agree more. Insurance companies should not be in charge of healthcare. We should do an entire webinar. And I would love actually for us to do, we've done a webinar before with Fred Pinzel, but I would love for us to do another webinar as well, Chris, on navigating insurance, where we could bring in outside organizations to talk about this as well. The reason I'm in Dallas is I serve on the board of Meadows Mental Health Policy Institute. And so I'm here for a board meeting, and all of what they do is focused on mental health policy, legislation, insurers, right? So there's a lot of folks that are really working hard to do this work. And a lot of us are trying to do our part in different ways within and outside of the OCD world, which will all impact OCD care.
If I could plug real quick, if I could plug the conference again, there's a talk on this also. If you can make it to the online OCD conference this weekend, I know Shannon Switzer, who's with NAMI, the National Alliance of Mental Illness, is part of that panel. I'm not sure the other people, but they're doing a whole panel on how to navigate that as well. So if you can make it, or at least if you can't make it, but want to sign up to access the recordings, there will be a talk on this as well. And then, like Liz said, it'd be great to do a follow-up on here as well.
Yeah, and I love so many of y'all are giving really good, helpful information about how to navigate it and what things look like and how to kind of get different funding, which is great. So yeah, awesome to see each other kind of supporting and giving each other really good feedback and thoughts. I am just still working my way through. All right, Chris. So we'll go to Stacy at 11:42. How do we know if the rigidity is autism spectrum or a combination? Is there a different approach for treating a child who is neurodivergent?
Yes, and more yeses. It's really important if you have autism spectrum disorder and OCD to work with somebody that feels comfortable. I'll never forget, I don't remember where it was because it wasn't the IOCDF conference. I was somewhere and somebody on the panel was asked if OCD treatment was different for people that also have autism. And the person was like, absolutely not, I treat it the same. There are certain nuances. Now, it doesn't mean there's a whole different treatment and things, but it's really important. And the reason I say that is because I don't have personal lived experience with autism, but I have family members with it who don't have OCD. And a lot of the behaviors could absolutely be misdiagnosed with autism. And that's what we see a lot of times with our clinic. We get people that have autism and are misdiagnosed. And just like you said, like there's rigidity, Stacy, in it. Like my nephew wants to have his meal at a certain time. He wants to watch his movie at a certain time. If I say to him like, hey, I'll watch the movie with you at 8:15 and it's 8:17 and I'm not there, he gets very agitated, right? And he does really well with structure. that isn't based in an obsessive compulsive cycle that we see in OCD. So what we want to recognize is like, why is the rigidity? So for instance, like I had to go to bed at the same time and wake up at the same time every day when my OCD was at its worst. If you ask me why, it wasn't that I do bad with not having structure. It was because my brain with my magical thinking said, if I don't go to bed at 12:45 and wake up at 9:45, something bad's going to happen, like my mom dying. So that's why it's always important to kind of look down and see what it is. People can have both. We see a lot of comorbid autism with OCD. And so you wouldn't use ERP to treat the autism. You're not treating the autism, right? You're treating the OCD components. And so when somebody has both autism and OCD, when they're not wanting to touch door handles or they feel things are dirty, but it's not a sensory issue, right? Or there's a lot of over praying and and it's not a fixation. It's more so a fear that God doesn't like them. So that's why I like the assessment process, is because as clinicians, it lets us feel comfortable that what we're moving forward is what you really are experiencing. And it lets the client know that everything about me is an OCD, right? Because that can be stigmatizing if you put their whole personality. Meanwhile, it's not. They just really enjoy certain things or need certain things to function.
Yeah. And I want to point out really quick that you guys, assessment is ongoing. So we are lucky enough to run a residential program. And the reason I say lucky enough is that we get to learn a lot about our patients in a condensed period of time because they're with us 24 hours. And so while, yeah, I might do a clinical assessment, my residential counselors are doing assessment after hours. They're reporting behavioral observations, and it really helps me to better understand my client. And so I would be lying if I said, hey, on day one, I always get it right. Like, of course I don't, right? As I get to know a client and get to know them, I better understand what might be going on with them. The more they disclose, the more comfortable they are, the more behavioral observations I have. And so I want to be really thoughtful too, that your diagnosis might change, right? You might come in and we believe it's one thing, and afterwards we have a way better understanding. That's good clinical care, right? It would be really bad clinical care if I was like, oh, I'm only going to stick with what I said it was from the beginning, but I'm not going to shift based on what I know and see and observe from each patient interaction. Now, it shouldn't shift every day, right? And it should be thoughtful, and we should be able to really show you what's going on and back it up, right? We can use the Diagnostic Statistical Manual, our DSM, to really say, hey, here's what we've also learned and noticed, and here's what you meet criteria for. That is why sometimes we're referring you to go get a full psychological assessment. Maybe some of us do it within our clinics like we do, but we want to understand what's the big picture, what is everything going on, so that we can have a really good, not just idea to present to you for a treatment plan, but be able to really back it with evidence and back it with numbers and back it with statistics. So yes, we treat neurodivergent patients very different, but very well. And we've done webinars specifically on this. And a lot of our clinics, when a patient comes in with ASD and OCD, our treatment does look very different, right? Because the way somebody with ASD might conceptualize things, or the way they may be more of a concrete thinker, and our approach needs to be much more kind of clear and behavioral, might look very different for somebody who really does better with abstract thoughts and abstract information, right? So we need to be thoughtful about how do we adjust based on the patient sitting in front of us and sitting with us in that room. At 11:50.
Real quick, one thing.
Question, so I'm going to put them all together because I think you're probably going to address them at the same time. So Michael also said, can you talk about OCD, anxiety, and Asperger's and autism? Many teenagers also who have autism spectrum disorders also have OCD and anxiety.
Yeah, real quick before Michael's, Katya said something earlier. The other thing I want to say too is if you go to a non-OCD specialist and her daughter got like 5 diagnoses from a thing, try to see a specialist to get the diagnosis, because a lot of times if BPD is what Katya said her daughter got diagnosed with, it's like a lot of times, first of all, you can't even diagnose a teenager with a personality disorder till they're 18, but a lot of times treatment centers will give somebody like 5 diagnoses, so it's okay to get a second opinion. But yeah, on Michael's question, absolutely, like we do see a lot of teens that have autism who have OCD and who have anxiety. We see that high comorbidity. Sometimes the anxiety, that's kind of what I guess the theme today is assessment, because that's why I like to really kind of figure out what's underneath. And so, I've worked with clients where they have a lot of anxiety in the classroom, and the parents brought them to us, think it's OCD, but it turns out like the kid really liked a certain chair. Like they had two different types of chair in the classroom, and one was like wooden, but one was this plastic, and he hated the texture of plastic. So he would have this meeting and he'd get to class a little late. And if he didn't get one of the chairs he liked and had to sit in the bad chair, he got really uncomfortable because of sensory. Well, that's not OCD, right? That's sensory processing. And so that's why it's important to know. But yes, there's a lot of comorbidity between that. The good thing is like we at the foundation have looped in the behavioral, the name's slipping my mind, for autism, the BC behavioral analysts, BA. Okay, Liz, I'm blanking. But one of the things that we did with the foundation is,
right?
Yes, thank you. All the different adjectives we're talking about. So there are people now on our directory that have worked with autism specifically and were trained in behavioral that felt like their training really lent them to go to a BTTI and work with OCD as well. So a lot of times the behavioral component of OCD treatment and treatment for autism can look very similar. And so a lot of times it's not too much for the person to learn both treatments. So we absolutely see it. And like I said, the assessment's important to kind of map out what specifically is causing distress, because sometimes with autism, it's not distressful, right? And, you know, somebody with autism may be really into something. We don't want to treat that. That's why I think it's so important, is because people with autism don't have a problem, right? There's no problem with somebody with autism. They're absolutely amazing people. There's certain things in the world, whether it's sensory or loud noises and stuff, that can really negatively impact them. And it's giving them the tools to navigate some of those situations. You know, my nephew hates loud noises, and, you know, if you touch him too tightly, right? There's nothing wrong with him. You're giving him tools how to handle those situations. So if you're treating an aspect of autism with ERP, that can be harmful. It's invalidating somebody's experience. But if the person with autism has a lot of anxiety because maybe they have scrupulosity and are struggling in class with over praying and can't pay attention and do good in work, the ERP will be the proper treatment.
Absolutely. So lessons learned from today as we start to wrap up is that it is so critical as a clinician that you understand the whole person that's sitting across from you, not just a piece of them, not just part of them. But treatment is not, oh, I hear some OCD, let me jump in and just do OCD work. Treatment is understanding everything that's going on, understanding someone's history, understanding all their different symptoms so that you can develop a treatment plan that's best for them. And sometimes that is solely with you. Sometimes it's in collaboration with other providers. And it is your job as a clinician to be ethical and to be thoughtful about, am I moving the patient forward? And do I have all the skills that I need? Or do we need a team? Or do they need to be referred out? And so I just say that because I want you to know that sometimes as providers, of course, we wish we could totally help every patient that's sitting across from us, but sometimes referring out is the most ethical thing we can do, and something that a lot of providers never would do. They would keep taking money and seeing you, even if they can't necessarily move the needle. So I want us to always be thoughtful. The best advice I ever got was from one of my professors early on in grad school. She said, with every single patient, I want you to think, if I have an active wait list of patients that are within my wheelhouse, would I still be seeing this patient? And if the answer is no, because you would have already terminated because they don't really need you anymore, it's your job to terminate. If the answer is no, because there's other people that would be better equipped to treat that patient, then you really need to be referring them out. So I love the conversation. I love the discussion, because OCD can look so different for every single one of us, and treatment can too, and we need to be thoughtful about that. Future presentations and webinars, we're going to do core fears, we're going to do language and OCD 101, and maybe we just do, actually, Chris, language and mental health 101, and then specifics on insurance. But biggest thing, you guys, iocdf.org. Our online conference is this weekend. I love the online conference so much. I'll be presenting a couple times, and I will also have office hours. So there are a lot of us that are part of the Room Brigade, which means that we're going to be dedicating time to meet individually with different folks who want to meet with us and connect. And you can go to iocdf.org to sign up for those hours if you want to get 30 minutes with me, with Chris, with John Grayson, with so many amazing people that are on the Room Brigade. So please be sure to do that. Chris, I'll let you take it from here, and I will see you guys next week.
All right. Bye, Liz. Just some final quick thoughts. First of all, Madison, I put in the chat, you were asking about support for a loved one. I run a free family and loved ones OCD support group every second Saturday of the month from 11 a.m. to 1 p.m. Pacific Standard Time, and it's free and you can join from anywhere. So please join us. That'll give you a lot of resources, and we'll definitely do some live streams in the future for family members. Second of all, yes, Amy, autism isn't an illness. I always get very frustrated and mad and protective of my family members when people talk about ASD as an illness. ASD is beautiful. People with autism and neurodivergent are amazing, and they don't need to be fixed. But OCD sucks, and that's why we're here, is to give you resources on how to get out of it. And then lastly, Grace asked if they could join the conference live. Absolutely. We're going to be there live this weekend. Go to online, iocdf.org/online OCD conference. Liz and I will be there live. So you sign in. The conference starts at 11 a.m. Eastern time, and you're going to be watching those presentations live. You're going to be part of the Q&A live. You're going to be part of the keynote and the wrap-up live. So everything is live, and it's being recorded. So let's say you go to one talk and you can't make another talk you want, you can watch the recording back.
That's my favorite part about the online conference, by the way. I hate that at the other ones we don't get to attend all the talks, and there's so many that I'm like, I wanted to learn. And so the online is so fun because I can highlight and then later go back and watch.
Yeah, so that's all I was saying, Grace, is like if you can't make a live talk, it's going to be recorded so you can go after. I have some clients that were like, Chris, I can't this weekend. We're out of town. But they signed up anyway so that they can watch the recording. So Liz and I will see you there. And then don't forget, we'll be back next Wednesday, same time, with Michelle Massey talking about a lot of different OCD stuff. But thank you for joining us. Liz and I are always honored that you come out and hang out with us. And thank you for all your amazing questions. Bye, everyone.
Love you guys.
Enjoy Dallas, Liz.
Thank you. Bye, y'all.
Bye.